Good afternoon. My name is Mark Larson, and I serve as the senior pastor of Lutheran Church of the Redeemer in Midtown Atlanta. And on behalf of my congregation, it is my distinct pleasure to welcome you all to the first forum in the Redeemer Poverty and Social Justice series, which we have called Death by Disparities: How Medical Bias Kills. At the beginning of this year, the Lutheran Church of the Redeemer launched a new strategic plan entitled Growing Faithfully, Serving Boldly. Together, we identified that one area of mission focus was to witness to the all-encompassing love of our Creator by building an inclusive community focused on justice and inclusion. Who could have predicted, given the events of this year, that such a vision would turn out to be so timely? This year, we have all witnessed long-standing racial division and tension burst into violence. With the arrival of the pandemic, we have seen how racial disparities in access to education, economic resources, law enforcement, and the justice system have been exacerbated and put into sharp relief. Another unjust disparity that has become glaringly obvious during this pandemic is access to quality and affordable medical care. That is the crisis our discussion will focus on this afternoon. I am pleased that it is not just Lutheran Church of the Redeemer that is taking on this mission. Faith communities across this nation have committed themselves to the hard work of dismantling racism and working towards reconciliation. Under the leadership of our own bishop, the Reverend Kevin L. Strickland, each congregation in the Southeastern Synod of the Evangelical Lutheran Church in America has been challenged to form a diversity and justice task force to lead this work. And so it is my privilege to introduce my bishop, Kevin Strickland, whose clear voice and witness has inspired all of us. Welcome, Bishop Strickland.
Thank you, Pastor Larson. It is a pleasure to be with you all today. For all who are participating, I greet you warmly in the name of the rebel rouser, table turner, justice seeker, equalizer of God's kingdom economics, Jesus the Christ. I greet you on behalf of siblings in Christ spread about these 4 states within our synod of Georgia, Mississippi, Tennessee, and Alabama. I am especially grateful for the work of Lutheran Church of the Redeemer, for putting this important conversation together, and for the work of its pastors and deacon, especially to Pastor Ron Bonner. Thank you. The book of Philippians reminds us of this. Do nothing from selfish ambition or conceit, but in humility regard others as better than yourselves. Let us each look not to your own interest, but to the interest of others. Let the same mind be in you that was in Christ Jesus. When I watch the evening news, or I read the paper, or frankly walk around my predominantly Black neighborhood, I am made fully aware of how present selfish ambition and conceit are sadly part of the fabric of our systems that we have created. And yet, what beauty would be revealed if we lived more by those words from Philippians, each of us looking not to our own interest, but for the interest of others. When I look at those statistics of people who have COVID-19 or who have died from this virus, it is astounding to see the imbalance of how many Black and brown persons are in the majority. And yet African Americans make up less than 14% of the US population, according to the US government report from 2019. And sadly, COVID-19 is just one example of the inequality that is present in the health disparities within Black communities. Is inequality making us sick? I would categorically have to say absolutely yes. Inequality is making us sick, but I would argue not just physically. Whenever human beings place a line between the haves and the have-nots, the top of the ladder and the bottom of the ladder, those within the circle and those without, we make the whole body of humanity suffer. Do nothing from self-ambition or conceit, but in humility regard others as better than yourselves. Let each of you look not to your own interest, but to the interest of others. Let the same mind be in you that is in Christ Jesus, or as St. Paul says to the church of Corinth, When one member of the body suffers, we all suffer. Inequality is making us sick, but it doesn't have to. We can cure the sin-sick soul. We can bring balm to the Gileads of our lives. To do that, though, I think we have to admit that part of what is making us sick as the whole people of God is the sin of racism. Inequality is making us sick, but it doesn't have to. As people of faith, we hold a truth greater than any human construction or political party. That truth is that we are called to live our lives worthy of the gospel, standing firm in the Spirit, striving side by side with one mind for the faith of the gospel, and we are in no way intimidated by our opponents. The gospel of Christ, which reminds us of gospel, is only good news when it equitably and equally is good news for all with God's ladder, God's circle that erases lines, God's justice, God's grace, and God's love for all. Inequality is making us sick, but I don't think it has to continue to do so. We have work to do, church, but it is work that is holy, it is needed, and yes, it is work we have already been called into as a result of our baptism, when we promise to strive for justice and peace in all the earth. I am committed to do my part in working with you and others in helping to combat health disparities, but more broadly, inequality, for it need not continue to make anyone sick. Thank you for this opportunity to be with you. I look forward to this conversation, and I am grateful for this distinguished group of panelists and all who join us for this important conversation today. May it not just be words heard, but words lived that change lives. I would now like to open us up with prayer. Let us pray. God of justice, we pray that we may become your balm to all the Gileads of our lives, creating systems and opportunities that offer healing and wholeness to all who are weary, sick, or carrying heavy burdens. We pray that we will continue to call on systems of power and those in authority to care mightily, equitably, and equally for all of your children. We will sing your canticle of justice for all until this world and all therein turn, and all are able to dwell in unity. We give you thanks for this opportunity of learning and listening. But lest we stop in this moment, God, send us forth, letting the fires of your justice burn. Triune one, in whose mighty name we call on and in whose mighty name we pray. Amen.
Thank you for joining us, Bishop Strickland, and thank you for those stirring words. To address the issue of medical bias, we have a panel of distinguished experts who I will just briefly introduce now. I'm going to ask them to turn live, and they're already on that, and give them, I will give more details about each individual before their specific presentations, but I'd like you just to give a wave as I announce your names so folks can begin to connect names with faces. We have Dr. Kamara P. Jones, adjunct faculty at the Rollins School of Public Health at Emory University. Dr. Chris Parker, Director of Population and Global Health at the Andrew Young School of Policy Studies at Georgia State University. Dr. Jada Bussie Jones, Professor of Medicine at Emory University's School of Medicine. Dr. Tracy L Henry, Assistant Professor of Medicine at Emory University School of Medicine. And Ms. Barbara Baylor, Coordinator of the Racial and Ethnic Health Disparities Task Force for the United Church of Christ Wider Church Ministries. When all of you registered, a number of you submitted questions for our panelists, and following all 5 presentations, we'll have about half an hour for Q&A. Now, if other questions occur to you during these presentations, please feel free to submit them through the Q&A function at the bottom of your screen. Pastor Ron Bonner, who is our Associate Pastor for Community Engagement and the staff leader for our Diversity and Justice Ministry, as well as Pastor Jonathan Trapp, our Associate Pastor for Faith Formation, are going to be compiling all of those questions, and they will ask them to the appropriate panelist. Now, if you, again, have technical difficulties during any portion of this presentation, please use the chat function. Our support staff is monitoring that, and they'll do their best to help you out. So let's get started. Our first presenter is Dr. Kamara Phyllis Jones, a family physician and epidemiologist whose work focuses on naming, measuring, and addressing the impacts of racism on the health and the well-being of the nation. She is the past president of the American Public Health Association and was the 2019-2020 Evelyn Green Davis Fellow at the Radcliffe Institute for Advanced Study at Harvard University. She has taught at the Harvard School of Public Health, Morehouse School of Medicine, and the Rollins School of Public Health, as well as serving as a medical officer at the Centers for Disease Control and Prevention. In her presentation this afternoon, she will set the context for our discussion through personal storytelling and will give us some allegories that will help clarify and help us to clearly name racism so that then we can move into action. Welcome, Dr. Jones.
Thank you very much. Thank you, Pastor Larson. I appreciate the bishop's remarks. Thank you, Pastor Bonner, for pulling all of us together. And so I will share my screen, and I am delighted to be here to be launching this conversation. I entitled my remarks, Achieving Health Equity Tools for a National Campaign Against Racism, with a subtitle of Naming Racism and Moving to Action, because that is what we need to do. 4 years ago in 2016, when I was the president of the American Public Health Association, I launched our association and our state affiliates and as many communities and other organizations as would join us in a national campaign against racism that had 3 tasks. The first, to name racism, because that's the most important first step. Because if you don't say the word racism in the context of our national widespread denial, you're complicit with that denial. But beyond naming racism, we need to figure out, what do we do? So then we need to ask the question, how is racism operating here in all of our various contexts, in order to identify levers for intervention, targets for action. And then once we understand how we're going to dismantle this system, we need to organize and strategize to act. So in my brief time opening up this panel discussion, I'm going to give us very quickly tools to do each of those 3 tasks. The first tool, one for naming racism, is a 4-minute story that if I just have a little bit of time with any group, even used to be sitting on an airplane, then to talk about racism, this is the story that I would tell. It's one of my allegories based on my own real life experience. I call it Dual Reality, a restaurant saga. And the moral, not to be a spoiler, but the moral is that racism exists. So let me tell you what happened in my life. As a first-year medical student, I was, of course, very diligent, very studious. So as was my wont, one Saturday morning, I woke up early and I was studying, hitting the books in my apartment. And, you know, doing that all through the afternoon. And then some friends came over and they didn't distract me. We all got to studying long and hard. And by this time now it's getting late and we're getting hungry. And I had no food in the apartment, which was typical of me. My friends understood. They were like, never mind, Kamara, let's go into town and find something to eat. So we did. We walk into town and we find a restaurant and we walk in and we sit down. The menus are presented. We order our food. The food is served. Here we are eating. Not a very illuminating or remarkable story to illustrate racism, not yet. But as I sat there with my friends eating, I looked across the room and I noticed a sign that was a startling revelation to me about racism. So now you're wondering, where did you go to medical school and what did the sign say, Dr. Jones? Well, what did the sign say? The sign said, open. So now I know I've lost some of you. So let me recap. Here we are, sitting in a restaurant eating. I look across the room, I see a sign that says open, and giving no more thought to it, I would have assumed that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that now, in fact, the restaurant was closed due to the hour, but firmly closed, and that other hungry people just a few feet away from me, but on the other side of the sign, would not be able to come in, sit down, order their food and eat. And that's when I understood that racism structures open, closed signs in our society. That racism structures, if you will, a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even recognize that there's a two-sided sign going on, because it is difficult for any of us to recognize a system of inequity that privileges us. So, for example, it is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It is difficult for all Americans to recognize our American privilege in the global context. But those on the outside are very well aware that there's a two-sided sign going on, because it proclaims closed to them, but they can look through the window and see people inside eating. So, back inside the restaurant, to those who ask, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism. It's actually an empowering thing to name racism. It doesn't even compel you to act, but it does equip you to act, so that if you care about those on the other side of the sign, which is an if, but if you do, well, first of all, you could talk to the restaurant owner, who is, after all, inside with you, and you could say, restaurant owner, there are hungry people outside. Why don't you open the door, let them come in? You will make more money, and oh, the conversations we could have. Or maybe what you'll do is pass food through the window, or maybe you'll try to tear down that sign or break through that door, but at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of that sign. So this story has been to illustrate that, yes, racism structures two-sided or multi-sided signs in our society, that it creates a dual or multifaceted reality. And I actually have had the experience on 2 occasions of starting a 3-hour conversation, each time with this one question: how could people who are born inside the restaurant know something about the two-sided nature of that sign? And it was a 3-hour conversation each time, because there are many ways to know. My encouragement right now is that many people who have been born inside the restaurant have a glimpse, at least in these past 2.5, 3 months, that there is a two-sided sign going on. And so I'm heartened by that. More people are able to affirm that Black Lives Matter, or put together the words structural racism or systemic racism. But I have to tell you that, first of all, this system, racism, is not just the sign, it's the door, it's the lock, right? And if we just say a thing that I recognize there's a two-sided sign, then the seductiveness of racism denial, which is the staunch position of this nation, the seductiveness of racism denial, if we just say a thing, will lull us back into what I describe as the somnolence of racism denial in 6 months. If that's all we did, is we made a statement, we put out something on our website, we started having conversations in our book clubs, right? What we need to do is we need to act, to tear down that sign, to dismantle the lock, to take the door off the hinges. We must move into action, because if we act, we will not forget why we acted. If we just said a thing, then the seductiveness of racism may make us forget why we said that thing. Well, I owe all of us a definition of racism. So when I say the word racism, I'm very clear that I'm talking about a system. So I'm not talking about an individual character flaw or personal moral failing or even psychiatric illness, as some people have suggested, although racism can manifest in those ways. But when I say the word racism, I'm talking about a system of power, and a system of doing what? A system of doing 2 things: of structuring opportunity and of assigning value. And on what basis is the opportunity structured? And on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks, which is what we call race in this country. What are the impacts of this system? Well, when we do understand or acknowledge that racism exists, we understand that it unfairly disadvantages some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. That's the whole issue of unearned white privilege that we hardly ever talk about in this country because it makes some people, especially some people who are living as white, uncomfortable. And I have to say, I used to, almost apologize, for the discomfort people might feel when I would get to this part of my definition. And I'd say, well, if you feel uncomfortable, shake it off, stay with me, I'll tell you more stories. I don't apologize like that anymore. I say, if you feel uncomfortable, what you need to do is lean in, because I have come to recognize that for each of us, the edge of our comfort is actually our growing edge. But there's a third impact of racism, which is that it saps the strength of the whole society through the waste of human resources. And I could go very deep into this slide, but I'm recognizing the time and that I just have a constrained amount of time on this panel. So let me just say, if you have any questions about how that sapping the strength looks or about any part of the definition of its impacts, I welcome your questions. I need to say that as a medical, I'm a family physician, I'm a PhD epidemiologist. I actually have developed a framework of understanding 3 levels of racism to understand how could racism turn into health outcomes and how could we intervene. And I do not have time today to share my levels of racism theoretic framework in Gardner's Tale allegory. I published it 20 years ago. I've been telling it for 30 years. It's a cult classic, if you will, within public health and in parts of medicine. I highly encourage you to either get the 4-page paper or go to this website and look at the video of me telling that story, which the moral of that story is that yes, racism exists on 3 levels: institutionalized or structural, personally mediated or interpersonal, and internalized. And that if we want to set things right in our society, we must at least address the institutionalized or structural racism. Good to address all the levels at the same time, but we must at least address the structural, and when we do, the other levels may take care of themselves. So without further ado, those 2 stories, the one I told you, the dual reality, and the one I didn't tell you, the Gardner's Tale, are tools for naming racism. Very quickly, we must get to how is racism operating here. It's a legitimate story. A legitimate question, because racism is not a cloud or a miasma. It's a system with identifiable and addressable mechanisms in our structures, policies, practices, norms, and values, where structures are the who, what, when, and where of decision-making, especially who's at the table and who's not, and what's on the agenda and what's not. And if structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why. We can apply this to how is racism operating here in my child's school or in my community or in this church, or with regard to police killings of unarmed Black and brown men and women, or even with regard to excess deaths of Black and Indigenous and brown people from COVID-19, where what's happening is that Black and Indigenous and other people of color communities are more likely to become infected because we're more exposed and less protected. And once infected, we're more likely to die because we're more burdened by chronic diseases with less access to healthcare. Without being able to go into depth on each of these mechanisms of racism, the structures that result in racial segregation of our communities, and when you have residential segregation by race, then you have educational segregation by race, and then occupational segregation by race. So we are more likely to be on the front lines in these essential jobs that are poorly protected, poorly paid, all of that. And that's why we're more exposed. We're also more exposed because of disproportionate incarceration, because we're disproportionately unhoused and the like. The policies that limit personal protective equipment for low-wage essential workers, or the limitation of paid sick leave and the like. In terms of practices, the locations of our testing centers and our testing strategies. In terms of norms, the norms that underlie our national racism denial, which include our narrow focus on the individual, which makes systems and structures invisible or irrelevant, or the fact that we're ahistorical and act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance, or the myth of meritocracy, the story that goes something like this: if you work hard, you will make it. Well, I give you most people who've made it have worked hard, although not everybody who's made it has worked hard. We have some very prominent examples of that. But even as I give you that, most people who've made it have worked hard. There are many, many other people working just as hard or harder who will never make it because of an uneven playing field, which has been structured and perpetuated by racism, sexism, heterosexism, all of these systems of structured inequity. And when we deny racism, we are still asking questions. Why are those Black and brown and indigenous people more affected by COVID-19? Maybe they don't understand, or maybe it's something that they did, or maybe it's their fault that they're overweight and the like. And then the values that are being written into our crisis standards of care, the standards that hospitals are setting in place if they have one ventilator and only and 10 people who need it. So what can we do today? Well, we can look actively for evidence of two-sided science. Is there something differential going on here by race or gender or language or immigration status or zip code and the like? We can burst through our bubbles of experience to understand that just across town, there are people who are just as kind, funny, generous, hardworking, smart as we are, who are living in very different circumstances. We need to burst through our bubbles of experience to experience our common humanity in different circumstances. And churches really stand as powerful actors in that space. We need to be interested in the stories of others, believe the stories of others, and then join in the stories of others. We need to develop a sensitivity to the absence of who is not at the table, what's not on the agenda, what policies are not in place that if put in place could be quite protective. We need to reveal inaction in the face of need, because that's how racism most profoundly impacts our health and well-being these days. Structural racism that does not require an identifiable perpetrator most often shows up as lack of action, inaction in the face of need. But all of the action steps are not on the part of those inside the restaurant. Those of us outside need to know our power. We need to recognize that action is power, and especially that collective action is power. So I look forward to the following presentations and to all of our discussion together. Thank you very much.
Thank you, Dr. Jones. I don't think I'll ever look at an open and closed sign quite the same way. As a person who's lived in privilege, I've always seen it more as an inconvenience and not as a tool of exclusion. Just as a reminder to everyone, if you have any questions of our presenters, please use the Q&A function on the bottom of your screen to submit them. Again, we're compiling all of those, and if we have any time left, we hope to get to as many of them as we can. We're going to continue to move on to our next presenter, who is Dr. Chris Parker. Chris Parker is a research assistant professor in the Dean's Office of the Andrew Young School of Policy Studies, and is the director of Global and Population Health at Georgia Health Policy Center. He holds a leadership role in many of the center's projects related to public health and program evaluation. His areas of expertise include strategic planning and evaluation, with a particular interest in projects that link population health and healthcare. As a trained family physician who has worked with underserved populations and faith-based organizations, Dr. Parker brings his clinical and community experiences to bear in addressing current and long-standing public health issues. In his presentation today, Dr. Parker will help us get a handle on our local situation here in Georgia and demonstrate how COVID-19 has pulled back the curtain on health disparities in Georgia and in the Southeast. Welcome, Dr. Parker.
Thank you very much, Reverend Lawson, and I also want to echo my thanks to the rest of the clergy who helped to set all of this up. It's an honor and a privilege to be able to participate here, and I think it's extremely forward-thinking for us to be able, I think it looks like almost 100 of us, to be sequestered having this conversation on the Sunday that the football kicks off in the South. It makes you recognize that there's some folks who have their priorities right, and I'll leave that there. So happy Sunday, everyone. Thank you for joining this discussion. When I heard the title, Death by Disparity, I thought that really sounds like an excellent name for a book. The sad thing is that it deals with two issues which are only too real to us here in the Southeast. And so my role is to help set up this conversation that we will have this afternoon with a few facts about health disparities. At the end of the presentation, there'll be a question that I will have for the group that hopefully we'll be able to kind of parse through at the end of all of the presentations. Pastor Mike is going to help me by moving these slides along. My wife tells me I'm long-winded, and so he'll help me keep things on track. And so Pastor Mike, if you could move on to the next slide, I'll get us started. Thank you. So to establish this discussion, I thought it would be important just to ensure that we are all thinking about some of these words we hear bandied about in the same way. When we talk about health status, we're really talking about the health of an individual or health of a group or population. When you start comparing that to other people or other populations across the country and sometimes across the world. There are these indicators that are used to do that, and we'll talk about a few of those today. Health disparities refers to the differences in the health status across different groups of folks. And invariably, sometimes we focus in on the outcomes, but there are these factors that allow for people to achieve their best health, which also contribute to health disparities, which I will focus in on a little bit as we move on. The term that I think sometimes gives us a little bit of bother is this concept of equity. And that really is everyone having the opportunity to attain their best health, their fullest health potential. No one is disadvantaged from being able to get to that place, especially because of who they are, where they live, or their social circumstances. And I wanted to use a picture that I've seen quite a few of these, and you probably have too, but the one that for me speaks best about how to make that difference between what we regard as equality, everyone having the same thing, versus equity, is this image that you're seeing just now. And the first, with equality, regardless of who the individual is, whether they're disabled, aged, very young, everyone's gotten the same bike. And as you can tell, it doesn't necessarily work well for some of the individuals to whom it has been given. In the second picture with equity, there are modifications to the mechanisms of movement here, those bikes, such that all have the opportunity to be able to move forward in their journey of life. Next slide. The last term I want for us just to kind of ensure that we have, because a lot of this will be the conversation that we'll get into around disparities, has to do with the determinants of health. And these are the factors that I mentioned that contribute to your current state of health. It includes the biology and the genetics, which I think we hear a lot about. It includes the behavior, which sometimes we also hear a lot about. But there are these pieces around the social, the physical environment, which oftentimes we don't recognize at policies or level that we might be able to use to address those. And this thing that is access to healthcare and the services that healthcare will provide to individuals. When you think about our health and well-being, each of those things contribute to a risk for premature death and for us kind of living on for longer periods of time. There's a lot of research that's gone into this, and I've seen the numbers change over time, not very significantly, but generally speaking, you will see that healthcare, the story here really is that healthcare contributes only 10%, but it's a 10% that we focus in on a lot, and we'll have a lot of that conversation today. It's one of the most expensive 10% here in the United States of America, but there are all these contributing causes and factors to folks dying prematurely that I want you to just quickly present that snapshot and for us to kind of dive into the conversation around why we have disparities across these areas. Next slide. Quick list of the indicators for those of you who might be data geeks and would love to be able to kind of say, so what are we talking about? I'm overarchingly looking at outcomes and its factors, and I've grouped them. What you're seeing on screen are the kind of high level ones. We talk about what's life expectancy, what is the expectation with regards to mothers and infants dying and dying early, chronic and infectious disease, what happens to populations, especially populations of color, where that's concerned. And you heard Dr. Jones mention a little bit about COVID. And then mental health, one of those areas that oftentimes we don't hear much about, and yet most of us, I think, have either a direct or indirect connection there. And then all of these factors, some of them we're aware of. The ones that I think everybody's probably very aware of is the influence of poverty and education and employment on one's ability to thrive. Housing, transportation, and then access, as I pointed out, are all these indicators that I think help to tell that story. Next slide. So that's, yeah, great. So the next thing I wanted to kind of highlight, as you heard from Reverend Larson, was, so we know that we have heard all over the news about the impact of COVID. and how it's really done a number on specific populations. Some of those populations we see highlighted on the screen. African Americans, the Native American community, I think just either yesterday or today was the first time in some of those communities that they actually had no new cases. The Hispanic or Latino community, communities that have comorbid conditions, most times chronic disease, hypertension, diabetes, many of which are linked to obesity. And then generally speaking, the elderly, and there's an overlay and overlap there with regards to some of the issues around chronic disease. In the next slide, I wanted to kind of just give some numbers to what you've heard a couple times already today. So when you look at the states in the Southeast, and depending on how you define the Southeast, it could be 12, it could be 7, you can pick it really. There is a very troubling trend that when you look at the percentage of Black and brown peoples in many of these states, in terms of a percentage of the population, and you compare that with the number of cases or the percentage of cases of COVID and deaths due to COVID, it is very alarming. So I've highlighted in this slide, I'm not going to go through all the numbers, where you can see in Alabama, 27% of the population are Black, and yet 50% of the cases end up occurring in African Americans, and 46% of the deaths occur there. Some of this data and information we're still parsing through because, as you can well imagine, it hasn't been very well collected in all states. But regardless of how you slice and dice it, the story here is, if you look at Florida, where the Latino population is larger, 26% of the population Latino, 43% of the cases end up being folks who are of Latin or Latino heritage. So that's an obvious story there. And I'm not going to spend a lot of time. We can talk some more about it, but I wanted to go on record and for everyone to be in the same space on this, that we are seeing populations of Black and brown people being more adversely affected by COVID. And that created this hue and cry about what needed to occur. But as you've heard, there is a bigger challenge, which for me is not just about COVID. You can move on to the next slide. When you look across what's been happening in states, and the United Health Foundation does a ranking of all the states every year, and what you're seeing in front of you speaks to the way in which those rankings are calculated. There's the behaviors linked to the community and environment, plus policy and clinical care, and they'll give you a rank. The next slide shows a map of the rankings across the United States. So Vermont for 2019 was the #1 ranked state, and Mississippi, number 50. What is telling here is when you look at the Southeast, which is, if you don't even know where the Southeast is, you just have to look at where all the red is. Many of those states are in 40 to 50 in terms of their rank. Georgia's last rank was 39, and we fluctuate 41. Every now and then we kind of dip into the red. But the general challenge here is that in the Southeast, we tend to have the worst rankings when compared to the rest of the country using the rubric that I spoke of before. The next slide speaks to the kind of distribution. I think there's another slide, if you can move on. Yeah, this is the slide around the healthcare systems. You will notice the same story. So this is a ranking of the systems, the hospital systems where people find care. And the story here, once again, is within the South and the Southeast, we do much worse in our rankings than the rest of the country. And in this specific case, the outlier was Alaska, which clearly isn't, because it's not a part of the US, you don't normally tend to associate the issue of racism or challenges related to race with Alaska. There are other challenges there that contributed to that. The following slide is just an overlay of the populations of people where we find the majority of African Americans in the country, where you find those deeper blue colors. And so the story I'm telling here is that the Southeast has some challenges. African Americans, all people of color living in the Southeast are adversely impacted by what has continued to happen over time. and has resulted in these disparities by both in terms of outcomes and factors. The following slide gives a picture of what has happened with where we find the Latino community. So I'll ask, tell that story, and the issue is still the same. And so I want for us, as we are beginning to have the conversation, to understand the overlay of where you live and the health that you have. So taking it to the next level, I'm going to ask if we can move on to the next slide. What about what's happening here in Georgia? And so there is another set of rankings, the county health rankings, which the next slide will get into what those look like. The county health rankings are done every year. It's a RWGF, or the Robert Johnson Foundation program, that sponsors it, work done by the University of Wisconsin. They look at all these measures and rank counties within states relative to each other. In the next slide, you will see the story of Georgia. The darker colors indicate where the rank is in what we call the final or last quartile. And so ranks from 120 to 159 are in dark blue when we talk about those health factors, the things that allow you to have your best health. And ranks 120 to 159 are in dark green when we talk about outcomes, which most times has to do with the way in which you actually find care and manage to have access to that care. The two maps could almost be identical, and what it tells you is that in the parts of the state where we know it's rural for the most part, some of those are regions where you actually have capital cities, but generally speaking, the bottom line here is that as you move further south, southwest, you tend to have a challenge with people finding their best health. The overlay in the next slide with the African American population is once again a stark. And I've also overlaid on this map what we know about COVID and where that's occurring in the state of Georgia. So generally here, what you're looking for is the color. The more blue it is, the more African Americans are in that population. And the larger the dark circle, it's the more there's been a challenge with regards to COVID. So we know in the Southwest, where some of the populations of African Americans are in excess of 50%, we've had a challenge there. Next slide. Some quick facts, and then I'll kind of move us toward the end. This is one that I'm thinking some folks might already have seen. You can get as much as a difference of 10 to 12 years in life expectancy, depending on where you live. There is a map that I think it's here in this presentation as well. Once you're below the 20, in those communities that are once again mostly African American, the life expectancy falls in significant ways. And that is something that should be alarming to most of us, that just by a few miles, you can have people living much longer and better lives than other people because of not having access to what they need. The table that follows, in the next slide, gives, and I'm happy to share this with others, gives a sense almost to the level of the community of where we find some of the challenges. So I mentioned below the 20, but when you look at what's happening in Clayton, when you look at the life expectancy highest and lowest in Cobb and where those are occurring, in DeKalb, you see a stark difference between what happens in Dunwoody and what happens towards Stone Mountain. And so there are these prevailing circumstances of gaps between people groups in not just being able to find health, but in fact, in being able to live on long and healthy lives. Next slide. So quickly, maternal mortality, just some things you should know. The rate, and when you think about the differences between blacks and whites, generally speaking, my rule of thumb is you can almost always think it's 2 times or more for the most part for most of these conditions. 2.6 times the maternal deaths of white women, 4 times higher than in the Asian Pacific Islander group. Next slide. Infant mortality, a huge challenge that we're having here as well. We've made some improvements, but the bottom line is that there's still a challenge here. And when you look at that third bullet, almost the last bullet at the end, speaks about it being 2 times higher than the white population. And this is an indicator of the health of any village community if your kids are dying before they actually have the opportunity to live their fullest lives. Next slide. Here's the kind of graph. If you know where the 20 is, the population that's below the federal poverty level. The darker hues will indicate where there is a huge challenge. Over 20% of folks who are living below the federal poverty level there. And that's all concentrated in these communities where we know that a lot of African Americans live. And there's also a strip heading up the 85, which you see in this one with the population uninsured. That dark green heading between DeKalb and Gwinnett, where there's a larger population of the Latino community. The numbers of uninsured skyrocket, sometimes above 20%. Next slide. The last set of slides, I just wanted to kind of reiterate what I was saying, regardless of how you cut it, slice it, or dice it, regardless of the disease condition. When you look at the numbers, mortality, prevalence, emergency room, it is perpetuated in almost all disease states. So I've listed a few there, highlighted. As your eyes are kind of running through it, wanted to once again say, when it comes to cardiovascular disease, hypertensive disease, you're looking at 2 to 3 times sometimes the rate, at least 1.5 times the rate in other things. Next slide. Cancer, huge challenge. Breast cancer, in particular here in Atlanta, up to 4 times the rate of African-American women who will die from breast cancer. Prostate cancer, I think most of us know that story. That affects a lot of Black men, more so than any other group. And we can unpack the why. You've heard Dr. Jones start to speak a little bit about what's the underpinning of all of that, why it is that our populations tend to find themselves in this situation. And I am hoping that we will have an opportunity at the end of this conversation for you to think about what the prescription is. What really do we need to do in an attempt to try and bring these numbers under control and ensure that all people have the best opportunity for their best health. Thank you.
Thank you, Dr. Parker. You really have pulled back the curtain on some of the challenges that we indeed are facing and here in the Southeast, in particular here in Georgia and in Atlanta. We're going to move on to our third presenter, who is Dr. Jada Bussie Jones. She currently serves as the Chief of General Medicine and Geriatrics for Emory at Grady Memorial Hospital and is the Director for Education at Emory's Urban Health Initiative. She works collaboratively to improve access and quality of care for Grady's patient population. Her leadership roles involve hospital-based, ambulatory, and community-based initiatives. Dr. Bussie Jones' academic work centers on interventions to mitigate health disparities and to understand and address such social determinants of health. Now, because of her work in developing curricula to educate medical students and professionals about cultural health disparities, she's exactly the right person to teach us all how bias and racism are actually manifested in clinical medicine today. So welcome, Dr. Bussie Jones.
Good afternoon. First of all, I want to thank my esteemed colleagues. I'm delighted to be on the panel today, and also our faith leaders from the Lutheran Church of the Redeemer for having this really important conversation. I'm hoping that after you've heard the great presentations and illuminating presentations from Dr. Jones and Dr. Parker, where we sort of unpacked what racism is conceptually and some of the numbers that are impacted there, that with this discussion, I might give some concrete examples, both of the determinants and its impact in clinical environments, and then importantly, spend a little bit of time talking about some strategies that we might use to mitigate the impact of racism and bias in our clinical spaces. So as a clinician, as a physician, I'd like to start off with a case because that always helps me to sort of frame things. The case is a 36-year-old African-American female who has a history of pulmonary embolism, which is a blood clot in the lungs. She comes in labor. She's about to have a baby, and ultimately she does by C-section because her labor was prolonged. She's doing quite well. That is until the next day when she develops some chest pain and some shortness of breath. And because she's had a history of blood clots in her lungs, she requests the test to evaluate for this and then treatment for a pulmonary embolism. But that's not what happened. Her nursing staff that was caring for her and even the physicians thought her pain medications were causing maybe some confusion, and they decided to just observe the patient, to just watch and wait. So she continued to have symptoms and to express desire for evaluation. And after some period of time passed, and after pleading with the staff, that the test was ultimately finally performed and did in fact reveal multiple submassive pulmonary embolism or blood clots. And for many of you, this case may sound familiar. She just played in the US Open. This is the case of Serena Williams before she gave birth, or right around the time that she gave birth to her beautiful daughter. And the point here is that this is an example of someone who was not heard or not seen, and whether it was because of race or gender or some other instance, Serena Williams is someone who has fame and power and money. And so if it can happen to Serena, it could certainly happen to any of us on the call today. And unfortunately, for better or for worse, the patients that I care for at Grady Hospital. So I think that this sort of gives a lens to the conversation that we're talking about today, especially in the clinical context. It's also important to know that our country is becoming more diverse, and we expect by 2050 that whites will no longer make up the majority of the population, will make up less than 50% of the population. So issues around race and racism are going to be increasingly important for us to think about. Also, as we've all been talking about for today's session, that these are really challenging times, that we're grieving, we're hurt, we're mad in many cases, but these issues around race and racism, and I just applaud you for having this discussion and in thinking about it before more recent events. But I talk about this with our medical students because talking about race and racism and bias impact the health of our communities and our patients. And this was already discussed by Dr. Parker, the impact of COVID, and that sort of laid bare issues of inequity around Black and brown people in this country. But this is not the first time. We've known about this. And in fact, during H1N1, another pandemic that happened in 2008, there was a conceptual model that was given by a Dr. Blumenschein, where he described concepts that are very relevant today when we think about COVID. What he described is that race and racism ultimately impacts differences in social position. That race and racism, as described by Dr. Jones, can impact, our investment in communities, the quality of education, the amount of education you have, which can in turn impact our occupation, and thereby impacting our exposures to the virus. In that case, it was influenza. In this case, it's COVID. But how much, whether you're an essential worker or whether you can work from home, whether you live in a house with other multi-generational family members, also whether you're more or less susceptible to a disease. So some of the chronic conditions that are themselves related to the structural determinants of disease as well. And then finally, I'll spend a little bit of time talking about inequities in treatment. So there are even differences once the disease is developed in terms of how you are treated. Do you have access to a primary care provider? Do you have health insurance based on your occupation? Because in this country, our insurance is very much tied to our jobs. And then finally, are you receiving the same quality of care? And we'll talk a bit and unpack that a bit in just a few moments. But all these things are additive and impact in multiple disparities and result in unequal levels of illness and ultimately death. So again, just to summarize, racism can impact poor investment in education and communities, limit employment opportunities, and then therefore, by limiting our insurance and other things, limit health access. So this was mentioned by Dr. Parker. I'm not going to go into this here, but just as a clinician, I find it incredibly humbling that clinical care is only 10% of what happens in terms of our risk of death. And that, so I really begin to tell our students that we have to think about this broader context. We have to learn how to get diagnosis and treatment plans right. Of course, we will always be clinicians, but if we really want to think about the health of our patients, we have to better understand some of these social and structural things that drive health in the first place. So I'm just going to share with you one example that I think can sort of bring some of these issues home, and that's housing. And here I'm going to talk about home ownership by race and education. So to just orient you a bit, each of these collections of bar graphs here represent the amount of education that one has. So these folks have less than a high school education here. These folks are high school graduates. These folks have some college. These folks have a bachelor's degree or higher. And then within each category, the blue line represents racial and ethnic groups. So these are whites, and the gray represents blacks. And what you can see is that for every education level, that whites are more likely than any other racial and ethnic group to have home ownership, so more likely to own a home. But what I think is remarkable is that for blacks who have at least a college degree or maybe a doctorate, that they have similar rates of home ownership when compared to whites with less than a high school education. And they've also done studies where they look at, loan approval rates by credit scores, for example, and that at similar credit ratings, that blacks are less likely to receive home loans. So your next question might be, why does this matter? What does it matter if someone owns a home, and what does it have to do with how healthy they are? The research suggests that relative to renters, that homeowners have a better physical health, lower childhood injury rates, higher and more positive mental health, and lower blood pressures. And that these benefits are independent of their socioeconomic status, so that poor homeowners are more likely to have better health outcomes than poor people who are renting their home. There's also a generational component where children of homeowners are more likely to graduate from high school and do better on standardized tests. And I just showed here that neighborhoods also matter. Dr. Parker went over this very well. In Atlanta, we call the Bankhead-Buckhead difference, that just where you live in your neighborhood can have an implication as well. Atlanta is not the only city where that is applicable. Researchers have talked about something called the American Apartheid, where they compared many US cities to apartheid-era South Africa and found that there were very similar rates of segregation. This was segregation primarily by race, but also by income as well. And the implications of that are really important. So poor neighborhoods, minority neighborhoods had less access to municipal service. There were differences in transportation availability, slower responses in terms of EMS times, more policing, as we've been talking about in the news, decreased purchasing power, so likely having poorer quality at higher prices, less access to medical care. Healthcare systems and primary care offices are less likely to set up a shingle in certain neighborhoods. The schools may be poor performing because they have less investment. There may be more exposures to environmental toxins and hazards like lead and other pollutants. So I've given you one example of structural racism, how it can be tied to a determinant of health, and I've just used housing as one example. Now I'm going to turn it over to our clinical role, which is kind of the space where I live, my domain. Before I get started, I just want to give you one definition of implicit bias. Implicit bias are attitudes or stereotypes that impact the way we understand things, the actions that we take, and the decisions that we make in an unconscious or implicit way. So these things, it's important to know, are pervasive. It's in the air we breathe. It's in the water we swim in. We can't avoid them. We all have them. And importantly, they don't always align with our declared beliefs. So I might be giving a lecture like I am now about implicit bias, or I might have walked in a march for Black Lives Matter, but it is still very likely that I have biases against Black and brown people because that is the air that we breathe. Generally, our biases, but not always, favor our own in-group. So for example, as an African-American female, you might think that I may favor other women of color. And while that is generally true, especially if you're from a marginalized group, that it's not always true, because oftentimes, because of the air that we breathe of society, that we receive, marginalized groups receive the same messages as the larger society about their group, whether it's gender or race or ability or other things, and may internalize some of those biases about their own in-group. So as I said, we all have biases, and if you'll bear with me, I'll share a little bit of mine. This is me when I was a baby and my grandparents who were holding me here, and I show this picture not because I was such a cute baby or my granddad had such great taste in hats, although I know that's what you're thinking, but I show this as sort of the beginning of my biases. I often introduce myself now as a descendant of slaves. My grandparents' grandparents were slaved. My grandparents shown here were not able to go to high school because there were no high schools for Black students in that town. This town had a railroad track that was both a physical and metaphorical divide. And I spent every summer in my formative youth until I was about 12 years old in that town on both sides of the railroad tracks. My grandmother cleaned homes on the other side of the railroad tracks, and I have no doubt that my experiences in that town at that time color the lens through which I see the world, and for better or for worse, the lens through which I see my patients and my colleagues, and drive in many ways the work that I do today. But I want to say that I'm not alone, that researchers say that we're not born with racial prejudice, but by 3 months, we begin to demonstrate significant preferences for our in-group. And that gets indoctrinated over time. So then the next question is, if we all have biases, that I'm not alone in that, what are the impacts on our clinical care? Can we have those biases and still treat patients the same? Unfortunately, the Institute of Medicine, which is kind of one of the major stakeholders in medical care, and they did a report in 2002, a comprehensive report and review of the literature, and found that across healthcare, that minorities receive fewer procedures and lower quality medical care than whites. And that these differences persisted even when you control for things like insurance status, socioeconomic status, stage and severity of disease, or comorbid conditions. They also were at play even when you were in systems like a VA medical system, where you'd expect the economic differences to be much less because people are from similar backgrounds, and also the insurance coverage is not an issue. And they've also done several studies like this one. This picture here is from a study where they had actors who you can see are all in hospital gowns. They're all in the same setting, in the same clinical setting. They were instructed or directed in terms of their arm gestures. They had the exact same script, the exact same objective description of their symptoms of chest pain, same jobs, same insurance, everything objectively exactly the same. They then showed these videos to several physicians attending national meetings and asked them to give their diagnosis and recommendations for treatment, and found that even though objectively they were looking at the exact same information, that their treatments were differed based on race and gender, again suggesting biases. So while there are lots of studies, that I won't go into many more of those, that show similar trends, the next question that you might ask, at least I would ask, because I think all physicians are really wonderful in trying to do the right thing, is that how we as well-meaning physicians can treat people differently. Clearly, we don't go into a hospital room saying, I'm going to treat someone differently because they are purple or polka dot. So this model that's shown here was developed by Michelle Van Ryn and colleagues, where she came up based on some evidence with a conceptual framework for how well-intended physicians, how our biases might come into play. She talks about how even how we interpret the patient's symptoms, how we hear and see our patient interactions may be viewed through the lens of our own biases. So Serena Williams, as I was talking about before, is one example of that, how we hear the person's presentation of chest pain or other symptoms. There's also studies that she mentions where they looked at videotaped encounters and found that we interact with patients differently. So our interpersonal behaviors, how many statements of courtesy that we give, how much information that we give may differ based on not just race, but gender, age, and appearance of our patients. And then finally, our treatment recommendations. Whether we make assumptions about the patient in terms of their socioeconomic status, whether they might adhere to therapy, whether they have social support so they could be put on a transplant or complete a complicated regimen, that sometimes we make assumptions that may lead to undertreatment, particularly for our Black and brown patients. So we have talked a little bit about the structural racism on a determinant outside the clinical setting and inside the clinical setting. I'm going to spend these last couple of slides just talking about what we can do. What are some options or strategies for changing this? So the first thing is diversity. Having more Black and brown physicians can be a mitigating factor. There have been research, for example, that says that Black patients are more likely to get preventive services when they're cared for by Black physicians, that female patients are less likely to die of a heart attack when they're treated by female doctors. We also know that physicians that are from underrepresented backgrounds are more likely to serve in minority and poor and Medicaid populations. And while it's less clear at this point that Black or brown physicians or women physicians or any group of physicians are more or less biased than others, what is clear, according to research, is that race and language concordance, having a physician that matches you in terms of race and language, has been associated with higher levels of satisfaction, more adherence to therapy, so taking the medications that the doctor recommends, coming back for follow-up appointments, higher ratings of trust, and overall outcomes have been a result of that. In terms of individual things that we can do, I'll just share a couple of things, not everything on the slide here, but really thinking about the person as an individual. This seems to make sense, but instead of the diabetic in room 22, if you can really begin to learn more about the personal background and stories of our patients, that has been found to mitigate some of the biases that we have. And then taking perspective. So putting yourself in the other person's shoes. It sounds a bit cliche, but there's evidence that, for example, Black and Brown patients are less likely to be treated for their pain even when they're in the emergency room for a new broken bone. They break their femur, they're less likely to get pain medication. But if you ask the nurse to say, how would you like to be treated if you're in this situation, that has been found to mitigate some of the biases that the nurses may have and their pain medication is better managed. Also, I think individual things that we can do is one thing, but I think structural things that we talked about is really important as well. Workforce diversity, as we mentioned before, training health professionals about this broader context of health. Dr. Henry will talk a little bit about legislative and community advocacy, that physicians have incredible power if they were to engage in this. But even if you never become active in those kinds of things, I personally think it's helpful for clinicians to know about this in our clinical encounters. So instead of getting frustrated when a patient returns with high blood pressures, maybe I unpack it a little bit more to understand why they didn't take their medications, if they couldn't afford it, or if they had, they live in a food desert and I've asked them to eat fresh fruits and vegetables and they don't have access to it. Also humbling is that if we take the physician out of it and do more nurse-led, protocol-driven protocols, that has been found to minimize some of the health inequities and decrease the risk of bias. Also getting data. So looking at health outcomes by race, gender, age, other demographic parts. So even when we think about COVID, we knew that COVID was killing us, killing people and killing the population. But when we began to see those racial differences and get that data, we can begin to understand and unpack the challenges there. Dr. Henry may talk about some policies like expanding healthcare or national sick leave that might help in our structural framework. And then I think importantly, just like we're doing today, to strengthen partnerships between communities, including faith-based organizations, health departments, and healthcare systems as we go along this path. So my last slide, I will just summarize by saying that there are multiple determinants of health that all three of our speakers today have talked about. They are definitely impacted by structural racism and unfortunately have a role outside of the clinical care environment, from housing, the example that I showed you today, but education, transportation, employment, and really tons of other things, but unfortunately inside the clinical encounter as well. And that we will need to make changes in both the structural and individual way in order to see improvement. So with that, I will turn it back over.
Well, thank you, Doctor. You've made it clear how all of us, operate out of our own personal implicit biases, often unexamined, often unrealized. You spent so much time working with doctors, training them and mentoring them. What do you suggest to those students or those doctors you're working with, how they can decrease the impact of their personal biases on the patients they're treating?
Right. Well, I gave a couple of examples about individuation, but I often say that if people stop to think about how they would want to be treated, or if they imagine the patient as a family member, a CEO, you would like to think that you wouldn't treat patients differently if they were an executive, but if it were your family member, if you're not doing something that is the standard of care, if the patient has end-stage renal disease and they're not being put on a transplant list, that you really think about, are you making assumptions about whether the person can comply with therapy? And then also, because we know that racism does impact some of those determinants of health, that our patients are less likely to have insurance or transportation and have some of those structural barriers, that it's still our need to get the patient the quality of care that they deserve. So we'll have to work harder with social workers and community partners to get the patient the care that they need. So those would be my recommendations.
Thank you. And I don't think it's just for doctors who can ask those questions about how we look at other people that can help our, build more just relationships. Just a reminder to our attendees that at any time you can submit your questions, and please use the Q&A function at the bottom of your screen. We're compiling those questions, and We may run over a little bit. For those who can stay, maybe we'll extend the time a little bit. And also, if you're having technical difficulties in terms of the Zoom call, that's what you should use the chat for. So again, questions, Q&A, technical issues via the chat. Now, I think we can all agree that we've been excellently educated on how medical bias works and how it's a manifestation of racism in our nation as well as our local communities. So with that theoretical knowledge, now let's shift to the question, what can we do about it? How can we act? What can we do to level the playing field? So to help us get a little bit more active, a little bit more practical is our next presenter, Dr. Tracy L Henry. Dr. Henry is an assistant professor at Emory University's Department of Medicine and a clinical educator and attending physician in both inpatient and outpatient medicine. She's also the assistant health director in the Grady Primary Care Center and director of policy curriculum for Emory's Internal Medicine Residency Primary Care track. She conducts research on health disparities, health policy, and primary care and behavioral health integration. In particular, this afternoon, Dr. Henry can perhaps help us discover both individually and as well as in our own communities how we can take action to change or address the issues of medical bias. So welcome, Dr. Henry.
Thank you so much for having me here this afternoon to discuss advocacy for anti-racism. And it's also a pleasure to serve on such an esteemed panel with our other panelists. And so let us begin. Disclosures, I have none. This afternoon, I will be walking you through what is advocacy and why is it important, the skills that you need to advocate, different frameworks and levels of advocacy. And then finally, I'll end with 2 examples of advocacy at different levels as it relates to anti-racism. And so simply, advocacy is the act of pleading or arguing on behalf of someone or a person or a cause. And advocacy, why is it important? Advocacy is important because it's our social responsibility, and it's also an act of good citizenship. It involves taking all those health inequities and injustices that we are seeing in our everyday lives and then acting on it. And in fact, in Proverbs 31:8-9, it says, "Speak up for those who cannot speak for themselves, and for the rights of all of those who are destitute. Speak up and judge fairly. Defend the rights of the poor and the needy." And so Christian advocacy has been a long part of our history of change in America. And in fact, as we have here, Dr. Martin Luther King Jr. is noted to have said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And in fact, Dr. King used many scriptures and Christian principles to advocate against racism that led to many of the anti-segregation laws that were passed in the 1960s. But if you're still not convinced on the importance of advocacy, just remember, if you're not at the table, then you're on the menu. And so I would like to digress for a moment and discuss with you why advocacy is important to me on a personal note. And that stems from the inequities that I experienced personally growing up, and also in watching my sister die in the hospital while waiting a kidney transplant, my uncle who died from the consequences of subpar schizophrenia management and lack of nearby mental health facilities, and also discovering that my 21-year-old cousin and college student died from senseless gun violence. And further, I advocate because I came to the realization that just how limited my impact was when I was treating one patient at a time. In fact, my patients who leave the hospital, I'm able to improve their condition. One particular condition, their heart failure, often come back with something else. Maybe it's an issue with their blood pressure, their diabetes. And so with advocacy, it gives me the greatest opportunity to have the broadest impact on the largest number of people. And also with advocacy, it gives me a seat at the table. And with advocacy, I have a voice. We all have a voice, and it's a unified message that is multiplied by all of us when we stand together. And I also like to draw your attention to the table on the slide. And this is a quote by Shirley Chisholm, who's the first African-American woman to be elected to the US House of Representatives. And she said, "If they don't give you a seat at the table, then you bring a folding chair." So I pause here to ask you, what is your story? What brought you here today on this webinar? What are the inequities that you experienced growing up, or the things that you saw? What are those racial injustices, things that you may see on your job or in the school with your children? What is your story? That story is a powerful tool and message that we can use to frame our issues to our legislators when we're advocating for change. And also, to be an effective advocate, there are some skills that are required. And one of the biggest skills is just passion and having a clarity of purpose. And absolutely, the absolutely biggest skill is just the willingness to act. And so you'll hear me say throughout this presentation, act, action, advocacy, change, over and over again. But really what it requires is just the willingness to act. Unfortunately, advocacy is really skills that you already have. It doesn't matter if you are an introvert or extrovert. You just have to figure out what is your passion, what keeps you up at night, and being able to operate within your sphere of influence and knowledge of the things that you can do to make change in your communities or on your job. And you don't have to be an expert per se, but just be willing to be informed and use your voice for good. So on the next 3 slides, I will discuss some frameworks and levels of advocacy. And the biggest picture and take home here is that advocacy comes in many different forms and many different levels. And so when I think about advocacy, there's 4 questions I usually ask when I begin, and that is, who am I advocating for? Yourself or the community member? Who are you advocating to? Is it a policymaker? Or what are you advocating for? Is it increased access to healthcare services? Is it for Medicaid expansion? Is it criminal justice reform or some racism policy or practice? And then how are you going to do it? Is this something that you're going to do interpersonally? Is it something you're going to do on a community level or use media strategies? And often when we think of advocacy, which equals change, we often think about policy and legislation, but it's really much more than that. It's education. It's attending this webinar today and becoming more educated on the issue so that you can go back and educate your family members, educate your congregation, your colleagues at work. It's advocacy is fostering coalitions and networks and being engaged with your community to have a broader impact by all working together. It could be simply changing organizational practices. It's going back to your job. It's working with HR. What are your hiring practices? Who are you deciding are the leaderships of your projects or leaderships at your job? And are we bringing up the next generation? Those are all forms of advocacy. And this slide is simply to let you know that advocacy also occurs in different levels. If it's individual 101, all the way up into a national effort. And then bringing back to this term ACT, and as you'll see the acronym ACT, Action Changes Things, there's so many ways to get involved, and I won't go through all of these, but I have a ton of these listed on the slide for further reference. It could be a media strategy, which is one I like to use, in writing op-eds to get awareness out, because it can get out to a lot of people. Social media is an excellent way to get out. You have thousands of people looking at your tweets or looking at things that you post, and that's a way to engage, the sort of millennials and Gen Zers is by using social media. Another personal favorite of mine is holding town hall meetings. I like town hall meetings because you get to hold the leader accountable. So you invite your legislator, you invite your public health leader, you invite your boss if this is at work, and then you hold them accountable. You have an agenda, you have questions, and together you guys can decide how you push forward your agenda and advocacy for change. So what's next? I like to think that there are 7 steps to advocacy, and I won't go into the nitty-gritty detail of each, but just to let you know, the first thing is just simplifying a priority. You have to figure out, what are you advocating for? You can't change the world. You won't make this entire system of racism go away in America in one day. Then identifying a solution. What's your target audience, and who are your key decision makers? Who are your allies, and who are your potential opponents? And which method you're going to use on that previous slide. Is it an op-ed? Is it a town hall meeting? Is it a petition? Is it a policy change? Then you have to implement the step and then follow up and make sure it worked. If it didn't, maybe you need to go back to the drawing board. Maybe we need more allies. Maybe we need to address the people who didn't want to see our change go forward. So these are the 7 steps to keep in mind. And now I will switch gears to some specific examples of advocacy for anti-racism. And I'd like to start really revisiting and building upon Dr. Kamara Jones's levels of racism, and actually use this from the National Academy of Medicine, where they used her levels of racism and then added a few more here. And so we can actually pick how we want to address racism at these different levels and choose our advocacy issues. And I will personally discuss the interpersonal level. And this level to me is very important. And Dr. Bussie Jones mentioned this earlier. There are two ways that we really can see change, and that's at the interpersonal level and also at the systemic level. The interpersonal level is a way that we push forward changing culture and for sustainability. And as we heard throughout this talk, that we are not born racist, believe it or not, but our children emulate and do what they see and hear us say, right? And so I like to start at this level. And then in interpersonal advocacy, it's really just when we see or hear racism, we have to call it out. And so a lot of people may say, and I've heard people say, well, Dr. Henry, I don't feel as emboldened to do so. I don't want to be confrontational. I know it's wrong, but it's hard for me to speak up. And so today I would like to offer you some practical tips of how you can do that. And so you can, get this language in your vocabulary, practice some of these things so that when you hear it, you're ready and prepared to say something. And so that could be seeking clarity when someone says something off-kiltered or off-colored. You can say, tell me more about X, or, offer an alternative perspective, such as, have you ever considered X? Or speak your truth. I don't see it that way. I see it as this. And then also, perhaps you're someone that's a little bit stronger. You may just want to just set your boundaries and say, please do not say X around me again, or to me. And then moving forward to another, back to our levels of racism and addressing racism at the systemic level. To end racism, you do need policies and legislative change and action. So one particular example I'd like to delve into this afternoon is that our student group was very active during this time, and it's the Student National Medical Association. And going back to the 7 steps of advocacy that I mentioned, I'll kind of walk you through their process. So they're busy medical students. They spend 8 or 10 hours a day in class and studying. And so, they were thinking, how would I have time to participate in this movement and make meaningful change? And so beginning with those 7 steps of advocacy, number 1, they had to simplify their priority. They wanted to change and do a whole bunch of stuff, but they couldn't do all of that and stay medical students and become doctors later and be a part of our workforce. So they decided that their priority was to make everyone aware that racism is a public health crisis. That was their priority. And their solution was, I want to dismantle racism at the systemic level with some sort of legislative action or mandate. So they started there. Then they had to figure out who's their audience. Well, since Emory is in DeKalb County, their audience was the DeKalb County Commission. And next, so they had to figure out where the stakeholders, who's going to work with us on this and support us through this process. And so they had tons of allies. They had not only each other as part of the Student National Medical Association, but they also had all the other student groups on campus. They had the other SNMA chapter at Morehouse. They had all of us faculty, leaders, and mentors, and even our patients. Everyone was on board. There wasn't really anyone we could find that would oppose it, except for people who are for racism. And then so next was figuring out their method or their platform. So how are they going to do this? They said, well, I want to write a resolution, and that's what we're going to do. And after that, before they can even get to the resolution, they wanted to make sure that they could show that we had the support of the medical community in the Atlanta metro area. And so what they did is they started a petition, and they got almost 6,600 people to sign this petition, or 6,600 healthcare workers. And this was doctors, this was medical students, PA students, nurse practitioners, physical therapists, all sorts of healthcare workers signed this petition. The next, since policymakers like data, the student group also drafted a policy brief. And so when you go to meet with legislators, they usually like a 1-pager of what's the problem, and this is what's been done in the past, and this is what you want us to do to solve it. And so this brief was super helpful, and helping them frame the issue and come up with the data that healthcare and racism is a public health crisis in our area in the city of Atlanta. And so using that data, using all the support from the petition, using the data from the policy brief, they were able to draft this resolution to present to the DeKalb County Commission. We have here on the left the day that the leader, Jasmine Eaton, where the arrow is, was actually advocating for it and testifying to the board. And also there were other people there in support of the resolution as well. They were also testifying. And in completing 6 and 7 are our steps to advocacy, they implemented it very well, and then they monitored and followed up, and it was a successful advocacy effort. As you can see here, the board, the commission voted 6-0 unanimously and passed it that racism is a public health crisis, July 14th, 2020. It also got local news in the AJC, as you can see listed here. And so you might be saying to me right now, so what, Dr. Henry? You said racism is a public health crisis. Well, like, okay, I'm starting to see that. But really, if you think about it, as of August 25th, 2020, there are only entities like city councils and county boards in 20 states in the union who have so far declared racism is a public health crisis. 20 states, so not all the states. So I am very happy to know that we are moving in the right direction, but there's a lot of work for us to do in America. Other examples of ways you can get involved. I remember I said I love town hall meetings, and I participated in several in relationship to healthcare disparities and COVID-19, and having leaders to increase access to mental health services during the height of the COVID-19 pandemic here in Atlanta. I've also written op-eds, and this is another way if you, a person that don't want to be out front and talking to people, but you might want to be a little behind the scenes, but get your word out. Op-ed is a safe way to sort of do so without having to be out front or talking with a policy member or being at a town hall meeting. And this was in the AJC on COVID-19 and racism. I also co-authored with one of my colleagues, educational curriculum policies and parenting for anti-racism practices that begins in the preschool area. Again, another way to get the word out that racism is a public health crisis, and also to advocate for anti-racism, could be a peaceful demonstration, which we did here for White Coats for Black Lives back in June. And then finally, if you do decide to go down a road of, I think I want to influence policy and legislation, you need to have a relationship with your senators and your House of Representatives. And so you need to know who they are. And so I listed here the links here where you can look up to figure out who is your US senators and your House rep, and also your state senator and state rep. And then so in recapping, the 3 no's that you should know leaving this talk is know your message, be able to clearly define the issues that you want to address, do your homework on the issue. Know your targeted audience. Is it a policymaker? Is it a school board, city council? Is it a health professional organization? Then know your strategy for change. How do you want, or how do you know that you're going to be successful at the end? Is it because you asked specifically for more funding for our schools in our county? Did you ask to increase minimum wage? Did you ask for more policies against discriminatory practices? Then remember, effective advocacy has one key component, again, going back to action. So it's really figuring out what you want, what are you passionate about, and getting out there and doing it. And I would be remiss if I don't mention that everyone should register to vote. If you haven't done so already, your vote counts. There's the link there. Thank you very much. And I'm open for questions.
Thank you, Dr. Henry. That was great. Couple of questions or follow-ups that I have. You talked about advocacy for legislative change, and yet you stayed away from the word lobbying. Was that intentional?
Yes, a lot of times people, they actually confuse lobbying and advocacy, and really lobbying is just simply one type of advocacy. So not all advocacy is lobbying, which most people think it is, but all lobbying is advocacy. And in fact, a lobbyist is really just a person who is hired. They're paid to lobby, to influence legislation on behalf of an organization. So there usually are those folks that are paid to do the job. And we are not being paid. We are doing this because this is part of our social responsibility, and that we care for our people in our population.
Okay, and a lot of the way you presented it made it sound very, personal or individual. Know your strategy, know your thing. Do you see advocacy as kind of a solitary effort, or where do allies come in there?
Yeah, so advocacy definitely involves, as part of my steps to advocacy, it's really reaching out. You can do individual for for people who may be more introverted or behind the scenes, but definitely you need allies. We can't make change, especially for racism, alone. So you have to identify who your allies are. Like in our student group, they reached out to other groups at Morehouse, they reached out to other student groups on campus, they reached out to the attendings and faculty members. And so definitely, it's not a single solitary effort. It is a joint effort. And for a successful advocacy effort, it involves reaching out to allies and collaborating.
Well, thank you very much, Doctor. Our final presenter moves us from the clinical area of focus that we've had primarily this afternoon to an area of faith response. So obviously she's got my interest. Ms. Barbara Baylor is the coordinator of the Racial and Ethnic Health Disparities Task Force for the United Church of Christ's wider church ministry, the denominational ministries. And in her role with the UCC national staff, she serves both as a resource for local congregations, as well as a policy advocate on behalf of her denomination. Earlier this year, she was appointed as the UCC Disaster Ministries Health Liaison, and as such was the point person for the UCC's COVID-19 response. Ms. Baylor has a master's degree in public health from the Gillings School of Global Public Health at the University of North Carolina at Chapel Hill. So as I said, I'm especially interested in hearing from Ms. Baylor how congregations and other faith communities can respond to the issues of medical bias and health disparities. So welcome, Ms. Baylor.
Good afternoon. I am Barbara Baylor, and I am currently the coordinator for the Racial and Ethnic Health Disparities Task Force for the United Church of Christ. And I'm very honored and happy to be with you today on this program, Death by Disparities. And I'm going to be sharing some information about engaging the faith community in the work around health equity. If I can have that first slide, please. When I first heard of the title of this forum, Death by Disparities, my mind went to a story in the sacred word of the Valley of the Dry Bones. I'd like to open with that, a little bit of word from that. In that story, God told Ezekiel to say to the bones, God will put breath in you, and once again, you will live. The dry bones represented the people who were in a state of living death, in constant pain and misery, pining away with seemingly no end in sight. And they believed that their situations were completely hopeless. So too are many people today who are very dry, without hope, and in that state of living death. They have been traumatized mentally, physically, and spiritually by the effects of the legacy of systemic racism, which has increased the gaps and elevated higher rates of health disparities. The faith community, in partnership with public health, medical, and other social services agencies, can assist in giving hope to the hopelessness. Next slide. For every statistic, there is a face. Someone recently said to me that the people that we are describing are members of our own congregations, so that in many ways we are addressing ourselves. While statistical data only records, the faith community can show the tears and also wipe away the tears. Next slide. So, why faith-based organizations? It is important to recognize the church's role as a source of support, strength, and sustenance in overcoming the difficulties and adversities that people of color face today. For people of African descent, the church is the one place that they can go to revise their minds, souls, and spirits. In an article in the Pan-African Medical Journal on the role of faith leaders influence health behaviors, it was revealed that faith leaders could play a very important role in the health behavior of their congregants by influencing, affecting, and impacting health behaviors and outcomes through scriptures, social influence, and serving as a role model. The research also pointed out that congregants view faith leaders as having an immense influence over their health behavior. Next slide. So this diagram from the National Academies of Sciences, Engineering, and Medicine focuses on three important themes that I believe that faith communities can use in their thinking and their planning around organizing for health equity activities in their communities. And these three things are making health equity a shared vision and value. Number two, fostering multi-sector collaborations. And three, increasing community capacity to shape outcomes. So I'm going to look briefly at these three themes and give you some examples on how the faith community can make these work. Next slide. According to research between 2008 and 2012, there was a growing awareness of an involvement in social justice ministries among Protestant churches in the US. And it showed that 95% of pastors agree that care for the poor is mandated by the gospel. The promotion of justice is a core value in most faith traditions, and most people of faith do believe that God requires us to do justice, to care for the marginalized and downtrodden, and to help change unjust systems where possible. Next slide. One way that people of faith can help make health equity a shared value and vision is by approaching and addressing healthcare and health disparities through a faith lens and faith language. Adopting a faith-inspired vision of health for your church or Congress, such as the one that's before you on the screen, is a good way to begin. In 2007, Faithful Reform in Healthcare, the largest coalition of national, regional, state, and local health organizations, adopted this as its vision. It continues as a guide today for faith communities' engagement in future efforts around issues that are related to health and healthcare. So I encourage you to adopt this vision or use this vision and principles for your congregation or conference. Next slide. This is theme number 2, fostering multi-sector collaborations. In 1999, the former Surgeon General of the United States, Dr. David Satcher, stated this, and I quote, "Through partnership with faith organizations and the use of health promotion and disease prevention sciences, we can form a mighty alliance to build strong, healthy, and productive communities," end quote. Faith communities are essential stakeholders to address the many issues that are related to health and healthcare and health inequities. A key outcome of engaging the faith community in partnership is institutionalization, so that together programs can be developed and sustained. So this slide shows some of the faith-health intersections that can be accomplished by engaging faith communities. And I'm just going to highlight just a couple of them. The academic faith and health centers at Duke University, the University Center for Spirituality and Theology and Health, the Emory University Interfaith Health Program and its Institute for Public Health and Faith Collaboration. Another intersection that you see on the screen is denominational-based primary care. And this is an exciting one because the earliest hospitals were actually formed by major faith traditions such as Lutherans, Catholics, Methodists, Baptists, Presbyterians, Adventists, and Jewish, and other religious branding medical centers. And what I'd like to point out here is that in 1957, the Lutheran Evangelical Reformed Church and the United Church of Christ formed Advocate Healthcare in Chicago, Illinois, which is a successful healthcare system that's still in operation today. Another intersection that you'll see on the screen is congregational-based health promotion and disease prevention. And they highlighted the Health and Human Services Project of the General Baptist State Convention of Raleigh, North Carolina in the early 1970s it began, and they pioneered church-based health education to underserved communities. And I had the wonderful opportunity to work on this project in the 80s and early 80s, and I can tell you it was very successful. Another intersection that you'll see on the screen is federal-based, faith-based initiatives. One of the highest profile initiatives of both the Department of Health and Human Services, the Office of Faith-Based Community Initiatives, and the White House Office of Faith-Based and Neighborhood Partnerships has been the President's Emergency Plan for AIDS Relief, known as PEPFAR, and it was launched in 2003. It has been the centerpiece of the nation's global health initiative. Next slide. I want to just highlight again a couple of things I want to say to you about the Emory University Interfaith Health Program. I want you to know that it was started in 1980 by Dr. William Fogarty, the former director of CDC. And he worked with President Jimmy Carter to build this national and global public health agenda for the Carter Center with the vision of closing the gap on glaring health disparities. And they felt like the best partner to embrace this vision was the faith community. So the Interfaith Health Program was launched in 1992 at the Carter Center and currently still is in existence today, strengthening community networks and partnerships with faith communities. Next slide. Next slide. And I want to come back one more time and highlight the Partnership Center as another faith-based intersection of faith-based and government. The Department of HHS Center for Faith and Opportunities Initiatives is the department's liaison to faith organizations, and it helps faith organizations stay in touch with many issues that are related to their health that are in the communities. And you can go to this website, and on this website, you can join webinars and sign up for newsletters. Next slide. The third theme is increasing community capacity to shape outcomes. We know that capacity building includes education and training, and it is a key role to help our faith leaders build the skill sets that they need in order to work on issues around healthcare and health disparities. This unnatural causes is inequality making us sick is a wonderful tool guide and toolkit to help enhance your church's understanding of and interest in working on broad issues related to health and racial disparities. The toolkit helps organizations with organizing, educating, and advocacy skills. Next slide. This slide just shows that church programs under the umbrella of health ministries come in all different kinds of ways. Health ministers, caring congregations, lay health promoters, health cabinet, church-based clinics, parish faith community nursing. And I'm going to take a few minutes and just highlight two of these that I think are real important for faith communities as you engage them in this work. The next slide. The first one is the lay health advisors model. This is a model that can help you address health issues, including racial and ethnic health disparities, because while churches can be those sources of support, they can also be sources of stigma, bias, and misinformation, such as the cases we find out now in the current coronavirus, and also in several years ago with HIV and AIDS. So this model really does help dispel myths, rumors, and provides factual information. Members who take this lay advisor training go on to be certified as lay ministers of health. And you've heard earlier that the General Baptist State Convention had a very successful model has a very successful program using this model. So if you'd like more information about the lay health advisors model, I'd be glad to hear from you and talk with you a little bit more about this model. Next slide. The next model is the faith community nurse. How do we utilize faith community nurses in our congregations? They are licensed, registered nurses who take extra training to care for their members of a parish or a faith community. They can integrate faith and healing and promote health and wellness within the communities they serve. This program was founded by Dr. Granger Westberg in 1984. So on the screen, you can find out more information about how to introduce faith community nursing to your congregation by contacting the Health Ministries Association, the Westberg Institute, and also here in Georgia at Northside Hospital in Gwinnett County. There's a huge program there. And by calling the Health Ministries Association, they will be able to tell you other faith community nursing programs around the country. Next slide. I want to say a real brief word about mitigating unconscious bias in faith-based healthcare organizations. You see this on the screen. You can see this quote that says, in cases where racial, cultural, or gender bias is found to interfere with care, delivery, or treatment, a truly values-based organization will take prompt and compassionate action to see that such interference comes to an end. And this comes from the Catholic Health Association in one of their journals. And they also believe that those who provide healthcare in a faith-based setting should take care to align care delivery with their organization's stated mission and values. Next slide. Another way that we want to talk about mitigating unconscious bias in faith-based organizations, again, is by utilizing our faith community nurses or parish nurses. They are equipped to assist congregants in 5 strategic areas, recognizing personal beliefs and values that can lead to unconscious bias, acknowledging that a problem exists, empathizing with individuals and their circumstances to understand what they're feeling and to understand their situation. They advocate and support congregants and patients as they navigate their healthcare systems and providing education to help raise awareness and recognizing unconscious bias. So that's how we can utilize our lay health ministers and also our faith community nurses in mitigating unconscious bias in faith-based health organizations. Next slide. I'm going to go real quickly on this one. I just wanted to give you on the screen some suggestions for congregational activities that you can actually start now that are real easy to do while we're in this virtual time, a reality time of our lives. One thing is to build a wall of woe. That is collecting stories and pictures of how health disparities is affecting people in your church and surrounding communities. And you can post pictures on your church website, Facebook page, or your church newsletter. And this helps make the issues real for your congregants. Designate Racial and Ethnic Health Disparities Day, designate Health and Wellness Sunday, do action alerts, town hall meetings, pastoral letters, letters to the editor, and op-eds are a few. Next. I'm going to, the next slide, I'm going to skip over this slide because due to time, but also it kind of speaks for itself. When we talk about advocacy, there are things that faith communities can and cannot do. And if you're interested in finding more about this guide, you can see on the screen, this is a publication called Take Action, Public Policy Advocacy Guide. And it comes from the Justice and Witness Ministries of the United Church of Christ, and it's written for faith-based groups. And so you can see the link down at the bottom of this slide. So I want to move quickly to the next slide, which kind of tells you what we need to be, as a faith community, need to be advocating for right now. We need you to urge your congresspersons to urge the passage of a robust COVID relief package that would include the supplemental nutrition assistance, rental assistance, unemployment benefits, paid sick family and medical leave, and will address future legislation around the coronavirus pandemic. We also want you to urge your governors to expand Medicaid if you're in a state where they haven't expanded Medicaid. And lastly, we want you to speak for the affordable care coverage and access to quality health care. Next slide. So I really would like to close my presentation by ending with the same story that I started with on the sacred story of the dry bones. And will these dry bones live then? Can these dry bones live? Yes, they can, but only if we as a faith community are willing to address these dry bone situations in faith. If we fail to collaborate and communicate with each other to end inequities and disparities in the social determinants, we will continue the legacy of the dry bones, and many, many more will die or continue living in this death. The faith community must continue to empower itself and partner with others to help restore inequalities and injustices so that these dry bones can be transformed and connected with love, strength, courage, and a determination to live. Thank you very much. You can see my information on the last slide. Feel free to contact me if you have any questions or you want to learn about more ways to involve the faith communities in the area of health disparities and health inequities. Thank you.
Thank you, Ms. Baylor, and thank you to all of our presenters. You've just done a wonderful job of kind of laying out the wider version or vision, as well as some specific ways that we as individuals can advocate, as well as faith communities respond. Time is passing very quickly, and though we said we were going to conclude at 3 o'clock, with our panelists' permission, we're going to extend the time till 3:15, extend our broadcast for those of you who can remain with us, because during this time we've been gathering questions. Now, many of you submitted questions when you registered, and we have those on record. And we've also been receiving questions via the Q&A function. So for the next 15 minutes, I'm going to call it exactly at 3:15 for a closing, and then we're going to keep all those questions, and we'll forward them if we have not been able to answer them to our panelists that they can respond to you individually. But right now I'm going to turn it over to Pastors Ron Bonner and Jonathan Trapp. And can one of you give us our first question?
I'll give the first question, and it's going to be, some of the questions are going to be combined. But anyway, to what extent can we empower at-risk populations to improve their health to sustain through this and future widespread health trends, comorbidities predicting outcomes, poverty, obesity, access to care? And in addition, would you also include, what is your response to those that believe that minority access to education, gainful employment, healthcare, and housing is due primarily to lack of personal effort rather than systemic racism? Who would like to take that?
I would like to take the second part of that. The main challenge is that when people hear the word racism, and Dr. Henry, can you turn your camera on too? Yay, okay, so I see all of us. That when people hear the word racism, they think that you're talking about an individual character flaw, or personal moral failing. So the first challenge in our society is to help people understand that racism is a system. The second challenge, so the first challenge is to say that racism exists. The second, that it's a system. The third, that it saps the strength of the whole society. And the fourth, that we can do something about it. So that's kind of the arc of our work. But when people believe these four things, that when in our society we have such a narrow focus on the individual, which makes systems and structures invisible or seemingly irrelevant. So that makes people want to blame individuals. We are ahistorical. We act as if the present were disconnected from the past, and as if the current distribution of advantage and disadvantage were just a happenstance. So that leads into victim blaming, or like, why aren't you, right? The third is the myth of meritocracy that I already addressed. And then white supremacist ideology is the fourth of 7 values that actually, so white supremacist ideology, which is the false idea of a hierarchy of human valuation by race, with white people at the top as the ideal or the norm, which gives people who are living as white a sense of entitlement. It results in the dehumanization of people of color and fear at the browning of America that's underlying a lot of our politics. But those 4 things that I just gave you are 4 of 7 principles for 7 barriers to achieving health equity, but those 4 result in the denial of racism. those four things. And so as a church, I actually think it would be lovely, because those are in the values range of things. These are kind of cultural values or whatever. I now identify my 7 as the values targets for anti-racism action. But the church actually has a role in those. But as long as people grow up hearing Horatio Alger and pull yourself up by your bootstraps, then they are going to deny racism. So what we need to do is change those large societal, cultural values so that people can understand that systems do exist and they're existing today and having profoundly negative impacts on all of us.
So I just wanted to build on that, and in fact, I think I attempted to try and answer that question in the chat itself, and said I'd like to hear what Dr. Jones has to say about this, because I think that restaurant story. I mean, I'm telling you right now, Dr. Jones, I'll be using it often, with or without permission. That it is so true as a concept. I think to the way in which even this answer will play out. So a lot of folks who will say, hey, it's because you're lazy, you're not doing what you're supposed to do, why you don't have access. Those folks are already sitting inside the restaurant. So they're seen open. And they're not seeing how it could potentially be closed to others on the outside. And I think that is the challenge that we have. And I dare say for some of us who actually got into the restaurant, either before the sign flipped, or before they didn't flip the sign, they just locked it. So it's set open, but you still don't have access. We sit on the inside and we see what's happening outside, and we make these judgments about what people need to do. They just need to push the door. And you're going, but no, historically, that particular door has been closed. From a policy perspective, it's not fully open, or it keeps opening and closing. So how do we create a system where there are multiple entry points and that access is encouraged? And it's not just a sign that says, all right, it's open or it's closed, that there is an active way of bringing folks from outside into the restaurant. And what is the role of those of us who've come in helping to ensure that the door doesn't just have a sign, but it's open. We can see that it's open, and there's entry and exit as people so desire. So that's what I would add. And the last thing I'd say is that when we think about empowerment, and I had a community member once disabuse me of this, nobody comes into my community and empowers me. Power belongs to the community. The fact that you have a voice in my community is because we have ceded that power. And it helped me to understand how we think about power. But that empowerment, I think, when you think about the socio-ecological model, what can you do as an individual? What does the family do? What does the group do? What do the community organizations do? And ultimately, what do you do with policy? The biggest lever in terms of making things happen is at the policy, the systems, and the change that will happen environmentally. And that's where I think when you talk about empowerment, giving folks the opportunity to have the pursuit of happiness, like everybody ought to, by ensuring that the laws allow for that and advocating for that, I think that's huge. I think that is why we're having these conversations, to understand what are the things that together we can push on. And I think there's a question about low-hanging fruit, but what are the things that this is a no-brainer that we can make it happen? And then for the things which it feels like philosophically there is the inside and outside the restaurant, how do we structure the conversations that somebody gets the keys to go open the dang door and allow people in?
Thank you. Pastor Jonathan, do you want to ask a question?
Absolutely. This is another one that was submitted to us. The question is, how can we hold medical health providers accountable when they consistently are biased against patients but are never reprimanded? And then following on to that, as an advocate and family member of a patient, what actions can we take to ensure that medical bias doesn't happen? I'll open that to whoever would like to respond.
Sure, I will start, and I would love to get other thoughts on and in response to this. I think that this idea of medical bias, even as we're talking about policing, while I can't know what's in the heart of all police officers, I would love to believe that most police officers don't get up in the morning saying they want to hurt or kill a Black or brown child. And I also, as I alluded to earlier, believe that it is the best intention of every medical profession to serve their patients well. Having said that, that we are swimming in the same societal waters that build bias and racism, and so are not immune, unfortunately. How we begin to hold accountable, we haven't even, because of the denialism that Dr. Jones has referred to, we haven't even begun to have these conversations, let alone to look at the data. So even when it came to COVID, when we've been noticing these big inequities, many states don't gather racial data, so let alone to know how individual providers are performing. So if the Kaiser Family Foundation, for example, did a study several years ago where they asked physicians first, this was just about 5 or maybe 8 years ago, if disparities existed. And the majority at that time didn't even know that disparities existed, let alone that we could be in any way responsible for that. So I think we have to begin to have these discussions first, that as patients and advocates for your families, that asking questions, there's data that suggests that when you engage actively in your care, the more questions that you ask, that you are more likely to get better outcomes. And so being empowered, as we've been talking about, to engage and change care or to escalate your concerns to other people, I think that those are very real things. But as a system, this is something that we are struggling with and at its infancy, asking to gather the data, training ourselves, holding each other accountable, I think is the next step, but it's much, much farther down the path. But I think it's a really important question. I'd love to hear others' thoughts about that.
I just have a quick, going back to the restaurant saga, the question about actively looking for evidence of two-sided signs. So actively asking, is there something differential going on in my personal practice with regard to patients in this facility? So that's as opposed to being comfortable, well, it looks open to me. So I think that is the picture of what you just said, Dr. Bussie Jones, that people have to be willing to ask the question as opposed to assuming that, well, my intent is to do the same for everybody. So clearly I could not have had any differential impact. We're so much in our nation, even in our laws, about intent versus impact. Two things to know about racism. It can be through acts of doing as well as acts of not doing, and it can be unintentional as well as intentional. So we need to be clear about that. And I want to say, I want to hear what everybody else says, but I do want to, I'm having this burning desire now to, in the last 2 minutes of our time, to just share another quick story that I think will be eye-opening for people. So I don't want to do it now, but if we could reserve just like 2 minutes at the end, I would love to do that.
So I might add just a little bit of bright hope in some of the work that I do. We do some strategic planning with some of the provider associations, so the Medical Association of Georgia and the College of Physicians of Georgia chapter. And I can tell you that more and more, when people are thinking about what needs to happen for the next 5 years, there is some intentionality about understanding how folks who are card-carrying members might be practicing differently, and how to begin from the standpoint of medical students, beginning to have this concept of, as you are practicing, cultural competency isn't just like a course you do in second or third year and you're done. But there is more to the practice of medicine than just that course. And so I think there is an opportunity for a lot of these provider associations to be the way in which the groups might hold themselves accountable. It doesn't necessarily have to be as draconian as, punitive in the courts, but I think if there's a carrot that can be made to happen so that as providers sign on, there is a reality that where I'm practicing, it's diverse, there's history, there's context, there's need to understand that some folks are not seeing the sign as open. That might be something that I think we're beginning to see. And I know it's happening with medical students clearly, just given what Dr. Henry was saying in terms of the advocacy that occurred with the CAB. I think we're getting there. We just shouldn't take our feet off the gas, because I think it's going to require us to hold ourselves accountable as we make this work happen.
And I'll just briefly add, most of this panelists have already pretty much addressed the the question, but I will say that we are taking a deeper look at ourselves as physicians, as healers in medicine. And so specifically a lot of physician organizations, as Dr. Parker has mentioned, we're taking a deeper look in how we're practicing medicine. Dr. Bussie Jones mentioned a lot of the biases in medicine. And so we didn't know, we thought we were doing all the right things like Dr. Kamara Jones was saying. We didn't realize that we were following the rules, but the rules were rooted in systemic racism and how we evaluate our patients with kidney issues or with heart disease. And so those are the things now that we're just now starting to doing. There's a lot of research and journals in the medical world saying, oh, wow, all of these things we've been doing for 20 or 30 years were rooted in bias. And so what we're doing now is really taking a look at ourselves as the medical profession and changing how we practice medicine. And in terms of what you can do as an advocate for your patient, I usually give a talk to my church and to my community at health fairs on how to be your own advocate. And before you go, I always tell my mom and my sisters, make sure you come with a list and you come with an agenda, and don't be afraid to ask questions. So if you think something is outside of what you think is correct and what should be offered towards you, you think that there may be some sort of disparity in the way and the treatment that is being offered to you in the healthcare system, don't be afraid to ask questions. Always ask for the patient advocate. There's always an advocate or someone that you can ask in a clinic or in the hospital system. And so those are my two tips. We are making changes within our own house, in the house of medicine, but also when you go with your parents or sisters or family, make sure you always come with an agenda and not be afraid to ask for a second opinion or a reason or rationale. Why are you being offered the health care that you're being offered?
I'm going to say thank you all. And I'm going to turn it back over to Pastor.
Ms. Baylor was talking, but you're muted, Barbara. We didn't hear what you said.
I see. I see. I was going to say something very similar as to what Dr. Henry said. In the faith communities, we had, during our training for the lay health advisors, we have given them tips on how to talk to your doc or how to talk to your counselor, and conducted listening sessions to help them understand how to do that, because some people are very afraid. They're very intimidated by the physician that we're in, and they can't find the words to say, well, should I have that? Or can we do that? They don't know how to do that. So I was going to say that we need to be our own advocates too around that issue.
Well, I'm afraid that's all the time we have for questions right now. We promised to forward any questions to the appropriate panelists. We've had a lot of questions that we didn't get to. But Dr. Kamara Jones, you said you had a brief story to close us off?
Yes, thank you for honoring that. So the hardest thing right now in this country in some communities is to say the word racism, because people think that when you said the word racism, you're trying to look at them and say, are you racist or not? Or, you know, how racist are you? So this last story is to talk about how we must understand that the problem is not individuals, the problem is the system. So imagine that there is a cement factory spewing cement dust, and anybody who's around that factory any amount of time is going to have cement dust in their lungs. And this cement dust in all of our lungs is problematic. It might act different in different people's lungs. So my cement dust might make me doubt myself more. Maybe I shouldn't graduate from high school. Somebody else's cement dust in their lungs might make them feel like they can lean on somebody's airway for 8 minutes and 46 seconds and kill them with their knee. But whatever it is, the cement dust is problematic. But the question is, what do we do? So do we develop a kind of machine that screens how much cement dust each of us has in our lungs? And then if you have too much, you're voted off the island or you're put in jail or something like that? Well, I don't think that will work. So maybe we have a machine that extracts cement dust out of your lungs. Well, that's a good idea, right? But that machine is going to be, we're going to need a lot of them for all of us. And it's going to be working 24/7. And as people, new babies come, we're going to need new machines. So maybe that's not the answer. So what do I think the answer is? It's a 2 or maybe 3-stage answer. The first is for me to recognize that although the cement dust in my lungs and your lungs and everybody else's lungs can be problematic, the real thing that's causing this is not that we were born with it, but there's a cement factory. So the moment I recognize there's a cement factory spewing cement dust, I need to start my personal journey of being actively anti-racist by putting on a gas mask. Now, I recognize that gas mask is not going to take the dust out of my lungs, but it's going to prevent new dust from getting in my lungs. So now I'm walking around with a gas mask, and every time I see myself in a mirror, I'm remembering, oh my God, why am I wearing this gas mask? There's this cement factory. But also, you guys are going to start asking me, Dr. Jones, why are you walking around with a gas mask? Which is my opportunity to say, well, there is a cement factory spewing cement dust. Do you want more in your lungs? So then more and more of you might be motivated to put on gas masks. So that's nice. But is the answer to have lots of the whole population walking around with gas masks, and then we have to make little baby gas masks and old people gas masks? No, that's still not the answer. But as we get more and more people with gas masks, because we recognize the problem is the system, we're also going to look at that system, figure out how is this system operating here, and then we're going to go into the factory and we're going to shut it down. So the focus, even though the cement dust in our lungs can be problematic, what we need to do is to focus on identifying, naming racism, asking how is racism operating here, and then organizing and strategizing to act. And if people can understand that, yes, the cement dust in our lungs is making us act out either against ourselves or against other people, the real problem is the cement factory. When we focus on that, then people will maybe not be so afraid to talk about racism at all, because it's not a judgment, it's about the factory.
Thank you, Dr. Jones. And really, thank you to all of our panelists for the insight and your willingness to give of your time here today. It's really been a great investment, and we can see all of your passion and your commitment, and if I dare say, in religious terms, your faithfulness. So thank you all. I think all of us would agree that we have been truly blessed and challenged by the presentations. As Bishop Strickland said at the beginning of our gathering here this afternoon, church, we have a lot of work to do. So thank you to Bishop Strickland for your leadership, and for the leadership of our community engagement team here at Lutheran Church of the Redeemer, for putting all of this together. I hope all of you will look for future events in our Poverty and Social Justice series. And finally, thank you to all of you for giving of your time this afternoon. I know you all had many choices in how you were going to spend this afternoon. I know football season started today, but I believe that you choosing to be with us here today demonstrates your faithfulness and the hope that together we can build a more just and healthy society for all. On that note, I'd like to close us off with a final prayer and a final blessing. In the days of devastation and hopelessness, the prophet Jeremiah brought God's promise of hope to his city. Thus says the Lord who made the earth, I am going to bring the houses of this city recovery and healing. I will heal them and reveal to them abundance of prosperity and security. I will restore the fortunes of Judah and the fortunes of Israel, and I will rebuild them as they were at first. I will cleanse them from all of their guilt of their sin against me, and I will forgive all the guilt of their sin and rebellion against me. And this city shall be to me a name of joy, a praise and a glory before all the nations of the earth, who shall hear of all of the good that I shall do for them. They shall fear and tremble because of all of the good and the prosperity I provide for it. Gracious Lord, in our own days of destitution, instill your hope within us. Strengthen our work to rebuild our cities and our nation in ways that reflect your justice and love for all people. Let our cities once again be a name of joy and glory before all of the nations of the earth, so that all will give you the glory for the good and the security you provide us. Let the words that we have heard today become the words by which we live. Through your glorious name we pray. Amen. Thank you, everyone. Go in peace. Serve the Lord. Thanks be to God.